It is, it's a really strange feeling to look at a standard everyday pill bottle like the kind sitting in millions of medicine cabinets right now, and realize you are looking at the exact same biochemical mechanism used by East African hunters to bring down big game.
Oh, absolutely. It really shatters that illusion of safety we tend to associate with modern pharmacy. We like to think of medicines as these perfectly domesticated, purely benevolent tools.
Right, like they were engineered in a sterile lab to just do one specific thing safely.
Exactly. But nature is a lot messier than that.
Yeah, I mean, you take a pill for your heart, you expect it to help your heart. You really don't expect it to share a resume with a lethal arrow poison. But that is exactly what we are looking at today.
It is. It's a fascinating paradox.
Welcome to the deep dive, everyone. Our mission today is to explore a class of drugs known as cardiac glycosides. And we're pulling from clinical history, cellular biology, and pharmacology source material to really understand how these compounds force a failing heart to pump harder.
And crucially, we're going to look at why they possess one of the most terrifyingly narrow safety margins in all of medicine.
Right. And how they ultimately humbled modern cardiology. So, okay, let's unpack this. How do we even begin to categorize a drug that, straddles this razor-thin line between life-saving and lethal?
Well, I think we start by acknowledging that for a very long time, we didn't actually know what these drugs were doing on a molecular level at all.
Not a clue, right?
Not a clue. If you went back to the late 1700s, this class of drugs wasn't defined by a molecular target or like a chemical structure. It was defined purely empirically.
Just by what happened when you gave it to someone?
Exactly. It was defined by what it did to a dying patient.
It was essentially known as the thing that helps dropsy.
Dropsy, yes. Such an evocative historical term.
Yeah, for anyone who hasn't read an 18th century medical text lately, dropsy is the historical term for edema. It's, the severely swollen legs, the bloated abdomen, the fluid-filled lungs.
What we now recognize as the end stages of congestive heart failure.
Right. The patient's heart is just too weak to pump blood effectively, so fluid just backs up into the tissues. They are essentially drowning in their own body.
It's a horrible way to go, and this desperate situation is really what sets the stage for this incredible origin story.
Yeah, so in 1775, there's this British physician and botanist named William Withering. He's working in Birmingham, England, and he catches wind of this folk remedy from a local Shropshire herbalist, right? A woman known as Mother Hutton.
Yeah, Mother Hutton.
Mm-hmm.
And her recipe was this closely guarded secret. It was a complex brew containing roughly 20 different herbs and plants.
It's a total kitchen sink remedy.
Pretty much. But because Withering had dual training in both medicine and plant taxonomy, he was able to look at this concoction and immediately suspect that, 19 of those herbs were just window dressing.
Huh. So he knew they weren't actually doing anything.
Right. He deduced that one specific botanical ingredient was doing all the heavy lifting.
And through methodical trial and error, he actually isolates it. The active ingredient is the purple foxglove plant, Digitalis purpurea.
Which is still famous today.
Yeah. But he doesn't just stop at isolating it, right? He spends the next 10 years of his life systematically studying this plant on real patients.
He was incredibly meticulous.
I mean, he's varying the dose. He's changing which part of the plant he uses, like the leaves versus the roots. He's tweaking the preparation and just documenting everything.
Recording the successes, the failures, the severe vomiting, and yes, the deaths.
Which is wild to think about. Looking at his 10-year, 163 case study, Withering was essentially doing like early Silicon Valley A/B testing on human beings.
That's a very good way to put it, actually.
Right. He was running a primitive dose-ranging clinical trial centuries before the term clinical trial even existed in the medical dictionary. He's just iterating in real time on desperate patients, trying to find that razor-thin sweet spot between, curing the dropsy and killing the patient.
And he published all of this in a landmark 1785 paper. What Withering recognized and formally quantified for the medical establishment was that incredible duality.
The double-edged sword.
Exactly. He wrote that the drug had a power over the motion of the heart that was completely unmatched by any other medicine of the era. Yet, he was equally meticulous in documenting its brutal toxicity.
So it's a miracle cure that can also easily kill you.
Right. And what's fascinating here is that this empirical trial and error definition, just calling it a heart tonic, extracted from a garden plant that held for nearly 2 centuries.
Wow. 200 years of just trusting the plant extract.
Yeah, the shift to modern science didn't actually happen until 1957.
Okay, so what changed in 57?
An enzyme biochemist named Jens Scow discovered a microscopic structure on the membrane of our cells called a NAB plus K plus ATPase pump. It's essentially a sodium-potassium pump.
And this was a big deal, right?
It was a monumental discovery in biology. It eventually won him the Nobel Prize in Chemistry in 1997.
Okay, so we find this microscopic pump sitting on the outer wall of our cells.
Right. And by the 1960s and 70s, pharmacologists like Arnold Schwartz proved that this specific pump was the exact target of Withering's foxglove extract.
Oh, wow. So they finally found the lock that the foxglove key fit into.
Exactly. So the definition fundamentally shifted from a botanical description to a mechanistic one. A cardiac glycoside was no longer just a plant that treats dropsy. It became defined as a Na plus K plus ATPase inhibitor.
Which changes everything, because once you define a drug by its molecular mechanism rather than, its plant of origin, you realize the drug class is way bigger than just foxglove.
Much bigger. It includes uabane, which is derived from African trees and shrubs.
Right.
It even includes bufadienolides, which are these steroid compounds found in toad venom.
Toad venom. I mean, it points to this wild evolutionary convergence where completely different kingdoms of life plants in Europe, shrubs in Africa, amphibians, they all somehow figured out how to target this exact same molecular choke point in the animal cell.
Is nature finding the same lethal solution over and over again?
But knowing the target naturally poses a massive mechanical puzzle for us here. If the drug is just inhibiting a tiny pump on the outside of a cell, how does that make the physical muscle of the entire heart contract harder? It's not a direct A to B process, is it?
No, it's very indirect. To understand the mechanics of how this works, we have to look at the baseline state of a heart muscle cell, a cardiomyocyte.
Okay, set the scene for us.
Right now, as you are listening to this, every single heart cell in your chest is maintaining a very steep gradient of sodium and potassium across its outer membrane.
So there's a delicate balance being kept.
Yes, and that Na plus K plus ATPase pump that Scow discovered,
Yeah.
it's constantly burning energy to push 3 sodium ions out of the cell and bring 2 potassium ions in. The entire purpose of this pump is to keep the sodium levels inside your heart cells extremely low.
Okay, I want to try visualizing this to make sure I'm tracking the physics of it. Let's imagine the heart cell is an incredibly exclusive nightclub.
Okay, a nightclub. I like it.
And the Na plus K plus pump is the club's bouncer. And this bouncer is strict. His only job is continuously tossing sodium out the front door to keep the club completely empty of sodium.
Right.
So because the club is so empty, all the sodium outside the club is desperately trying to get back in. There's this huge pressure.
That inward pressure is absolutely crucial because there is a second, entirely separate protein on the cell membrane called the sodium-calcium exchanger, or the NCX.
Wait, NCX.
The NCX is essentially a biological turnstile. It uses that massive inward pressure of the sodium outside the cell to function. The NCX allows sodium to rush back inside, but it charges a toll.
A toll?
Yes. It trades 3 sodium ions coming in for 1 calcium ion being forced out of the cell.
Ah. So in the nightclub scenario, the NCX is like a side door. It says, okay, sodium, you can sneak back in here, but only if you drag a calcium molecule out with you on your way in.
That is a perfect way to picture it, yeah.
Nice.
Now, we introduce the cardiac glycoside, the drug. The drug molecule comes along and binds to our bouncer, the primary pump, and it partially inhibits it.
It distracts the bouncer.
Exactly, it slows him down. Since the bouncer isn't throwing sodium out as fast, the sodium levels inside the club start to rise.
Oh, I see. If the club is already filling up with sodium, the sodium waiting outside loses its motivation to use that side door.
The gradient is flattened.
Right. That desperate inward pull completely disappears.
And since the sodium is no longer rushing in through the side door, it is no longer dragging calcium out. The biological turnstile just stops turning. Consequently, calcium begins to accumulate inside the heart cell, where it gets loaded into the cell's internal storage unit, the sarcoplasmic reticulum.
So the next time the heart beats, there is a massive surplus of this extra calcium just sitting inside the cell, ready to be released. And calcium is the trigger, right? It tells the microscopic muscle fibers to lash onto each other and pull.
You've got it. With a massive flood of calcium, those fibers grip harder and pull stronger, resulting in a much more forceful contraction of the heart muscle. You get a harder heartbeat without the heart having to beat faster. And this is the crucial takeaway for anyone trying to understand pharmacology here. The drug achieves a stronger heartbeat entirely indirectly.
Right, it's a chain reaction.
Exactly. It doesn't stimulate the heart's contractile machinery directly at all. It simply creates a microscopic traffic jam of calcium by messing with the sodium bouncer.
That is brilliant. But there's a secondary effect too, right?
Yes, there's a bonus effect. These drugs also increase vagal tone. They stimulate the parasympathetic nervous system, which is the body's natural braking system, which actually slows down the electrical conduction through the heart's wiring, specifically the AV node.
So it's hitting the brakes on the electrical speed while simultaneously pumping up the physical strength of the muscle.
Which is a very unique combination.
Yeah, and that's why drugs like Digoxin are still used today to control the heart rate in patients with atrial fibrillation. It throttles those chaotic electrical impulses while ensuring the beats that do get through are forceful.
Correct.
But, I mean, creating a deliberate calcium traffic jam that feels like a very dangerous game to play, you're intentionally clogging up cellular machinery. If you just keep packing calcium into a heart cell, it can't just keep contracting harder indefinitely, right? There has to be a catastrophic breaking point.
There is. And the breaking point is electrical instability. We mentioned earlier that cardiac glycosides are a double-edged sword. That uabane extract from the strophanthus plant was used as an East African arrow poison for a very specific reason.
Because it stops the heart.
Because if you trap too much calcium inside a heart cell, the cell becomes electrically irritable. Calcium overload triggers rogue electrical signals. The exact same mechanism that makes a failing heartbeat harder at a therapeutic dose will cause lethal, chaotic arrhythmias and stop a healthy heart entirely at a toxic dose.
So the therapeutic index, the gap between the dose that helps you and the dose that kills you, is terrifyingly narrow.
Extremely narrow. In fact, if someone overdoses, they require a highly specific, very expensive antidote called Digoxin immune fab.
I read about this. These are literally sheep-derived antibody fragments, right?
Yes, they get injected into the patient to hunt down and neutralize the drug molecules circulating in the bloodstream.
That's wild. But the toxicity risk isn't just about a patient accidentally taking too many pills, is it? The source material outlines this massive hidden trap involving other medications, specifically the diuretics that are almost always prescribed alongside heart failure medications.
This is a classic pharmacological trap, and it's so important to understand. Potassium and digoxin actually compete for the exact same physical binding site on the bouncer, that Na plus K plus pump.
Oh, really? They fight for the same spot?
They do. If a patient has a normal amount of potassium in their blood, the potassium physically blocks some of the digoxin from binding to the pump, keeping the drug's effects in check.
Wait. So the diuretics that doctors prescribe to heart failure patients to clear fluid, those actively deplete potassium, right? They flush it out in the urine.
They do, yes.
Meaning the co-prescribed drug is essentially arming the digoxin to become toxic. If a patient's potassium levels drop, there is suddenly no competition for the binding site. The digoxin has free rein to completely take over the pumps.
If we connect this to the bigger picture, you're essentially removing the safety mechanism. You're allowing a normal prescribed dose to behave like a massive overdose.
That is terrifying.
And this specific interaction is exactly why emergency rooms deal with so many digoxin toxicity cases today. You typically have older adults with heart failure. Their kidney function naturally declines with age, meaning they already can't clear the digoxin from their bloodstream efficiently.
Right.
Then you put them on a diuretic that lowers their potassium. You create a perfect storm where a previously stable therapeutic dose suddenly tips over into lethal toxicity.
And when that toxicity hits, the symptoms are incredibly distinct, aren't they?
Very distinct, though sometimes misdiagnosed at first.
Because initially it masks itself as severe gastrointestinal distress, right? Like nausea, profound vomiting, loss of appetite.
Yes, the GI symptoms hit first.
But then it hits the heart's electrical system. You get this unique EKG pattern called bidirectional ventricular tachycardia.
Right, which is extremely dangerous.
To picture what that means, imagine the heart's main pumping chambers, the ventricles firing off rogue electrical signals from two different locations, just ping-ponging back and forth wildly. The heart is basically short-circuiting.
And we also have to mention the profound neurological and visual disturbances.
Oh yes, xanthopsia. Patients start seeing intense yellow-green halos around light sources.
It's such a specific and bizarre symptom.
It is, and this symptom is so iconic it has actively bled into art history. There is this enduring theory that Vincent van Gogh was treated with digitalis by his physician for his epilepsy, and that he may have been suffering from this exact digitalis-induced visual toxicity.
The yellow halos.
Yeah, some art historians argue this is why his late paintings, like The Starry Night, are so heavily dominated by those swirling haloed yellows.
It's a fascinating theory. It really bridges toxicology and art, even if, medical historians still debate whether his digitalis use was actually extensive enough to cause permanent visual distortion.
Right, it's debated.
But it certainly underscores how profoundly this drug infiltrates the entire nervous system, not just the heart.
Yeah, and speaking of the darker side of this drug's profile, we see the grim reality of Charles Cullen, the American serial killer nurse who operated across hospitals in the 90s and early
A
2000s.
truly horrific case.
He specifically weaponized digoxin's narrow safety margin. He intentionally injected lethal overdoses of digoxin into patients' 5e bags. And he knew that because heart failure patients were already on the drug, a sudden spike in toxicity could easily be mistaken for natural cardiac arrest or just a tragic dosage error.
It allowed him to evade detection for years.
Which is chilling. It's a reminder that a drug's brilliant partial enzyme inhibition is literally just poisoning the moment you cross that invisible line.
And the sheer danger of the drug force is a critical medical question.
Mm-hmm.
If the margin of error is this thin, if a slight drop in potassium or a minor kidney issue can trigger a lethal overdose, the medical community needed absolute statistical proof that forcing the heart to beat harder actually keeps these patients alive longer.
Right, because for over 2 centuries, from William Wittering all the way up to the late 1990s, the operating assumption was incredibly straightforward. Heart failure means a weak heart. Digoxin makes the heart pump stronger. Therefore, digoxin must be saving lives.
It just felt like common sense.
Nobody deeply questioned it until the medical establishment finally decided to run the math. Let's look at the 1997 DIG trial.
The DIG trial was an absolute watershed moment for modern medicine. Researchers took roughly 6,800 patients with heart failure and randomized them to receive either digoxin or a placebo alongside their standard therapies.
A massive study, and they ran it for years, right?
Years. And when they finally unblinded the data, the headline results sent shockwaves through the cardiology community.
What did they find?
Digoxin did not extend life. There was absolutely no difference in overall mortality between the patients taking the dangerous drug and the patients taking the sugar pill.
Wow, so it reduced hospitalizations, people felt somewhat better day to day, their shortness of breath was managed because the heart was pumping a bit more efficiently, but they didn't actually live a single day longer.
Exactly. And the data got even more sobering when researchers looked deeper. In 2003, the Journal of the American Medical Association published a massive reanalysis of the DIG trial data, led by Rathor and his colleagues.
What did Rathor find?
They looked specifically at the exact concentration of digoxin in the patient's bloodstreams, and they found a U-shaped mortality curve.
Meaning the drug was helpful at a very specific low dose, but the moment you pushed it higher, it reversed course and became actively harmful.
Right. Patients with very low blood serum levels, between 0.5 and 0.8 nanograms per milliliter, saw some mild benefit. But once the levels crept above 1.2 nanograms, which, by the way, was still widely considered a standard therapeutic dose at the time, mortality significantly increased.
Oh my God.
The drug was actively killing people, and they found this detrimental effect was especially pronounced in women.
So what does this all mean? It sounds like for generations, by aggressively aiming for higher doses to get a stronger, more forceful heartbeat, doctors might have inadvertently been harming the very patients they were desperately trying to save.
It is arguably one of the most humbling revisions in the history of cardiology. It forced the entire medical community to engage in a really difficult philosophical reckoning.
How so?
Well, for decades, medicine had conflated two completely different physiological concepts. We assumed that increasing contractility, making the damaged organ physically work harder, was perfectly synonymous with decreasing mortality, helping the patient survive. The DIG trial proved they are not the same thing at all.
It's like having an exhausted, overworked horse pulling a heavy carriage, right? Digoxin is the whip.
Oh, that's a brilliant analogy.
Yeah. Yes, whipping the horse makes it pull harder and run faster for a moment, but you are burning out the engine. You are accelerating the exhaustion.
Precisely.
Because that extra calcium we talked about earlier, the cellular traffic jam, it makes the heart pump harder, but the immense stress of that calcium overload actively increases the risk of those deadly electrical misfires.
And the medical community realized that forcing a failing heart to expend more energy was just the wrong approach. This is why the status of cardiac glycosides has been completely demoted in modern treatment guidelines.
They aren't the go-to anymore.
Not at all. It went from a first-line, life-saving miracle drug to a symptom-modulating adjunct. Today, heart failure is largely managed by drugs that actually improve survival, like beta blockers and ACE inhibitors.
So those modern drugs don't whip the heart to work harder.
No, they do the opposite. They reduce the blood pressure and the workload on the heart, giving the exhausted organ a chance to rest. That is what actually extends a patient's life.
Right. It's vital to clear up the lingering misconceptions out there about this drug class. Digoxin does not save lives in heart failure. More is absolutely not better, thanks to that U-shaped mortality curve we just talked about.
Very important points.
And if you are ever in a clinical setting watching out for toxicity, those famous yellow halos in a patient's vision, they aren't usually the first sign. The severe nausea, vomiting, and GI issues usually hit long before the visual disturbances do.
And we should probably also clarify that this lethal chemistry isn't just confined to the foxglove plant or African arrow poisons.
Oh, right. Oleander.
Yes, oleandrin, which features the exact same molecular mechanism, is found in oleander. And oleander is a highly toxic, drought-resistant ornamental bush that is planted in front yards, gardens, and alongside highways all over the world.
Yeah, accidental poisoning still happen today because well-meaning foragers mistake foxglove leaves for edible herbs like comfrey in their own backyards. They're totally oblivious to the fact that they're brewing a highly potent cardiac medication in their teapot.
It's terrifyingly easy to make that mistake.
It really has been an incredible journey exploring this today. We went from Mother Hutton's secret recipe in a Shropshire garden to the lethal arrow poisons of East African hunters to Jen Skou's Nobel-winning discovery of a microscopic cellular bouncer, all the way to the humbling reality check of the DIG trial.
That's a huge arc.
We took a plant that stops hearts and repurposed it to treat them, only to realize centuries later that the underlying math wasn't exactly what we thought.
It is a profound story about the limits of empirical observation and really the necessity of rigorous clinical trials. But before we conclude, there is one final, almost mind-bending debate regarding cardiac glycosides that reshapes how we think about this entire class of compounds.
Seriously, it's hard to imagine a twist bigger than what we've already covered.
I know, but listen to this. We've been talking this whole time about cardiac glycosides as alien plant-derived chemicals, right?
Yeah.
We view them as toxins we extract from nature and introduce to the human body from the outside.
Right.
But in 1991, a researcher named John Hamlin proposed a radical, highly controversial theory. After isolating a specific compound from human blood plasma, he argued that the human body actually produces its own endogenous ouabain-like hormone.
Wait, really? You were saying the human body might naturally manufacture the exact same chemical used as African arrow poison.
The theory posits that our adrenal glands naturally synthesize a microscopic amount of a cardiac glycoside-like substance to regulate blood pressure and manage sodium balance on a daily basis.
No way.
Now, while it remains heavily debated in the scientific community regarding its exact physiological role, the evolutionary implications are staggering.
That is wild. I mean, I'm going to leave you, the listener, to ponder that one as we close out. What if the foxglove plant growing in the garden and the ouabain smeared on the hunter's arrow aren't just hacking our cellular machinery from the outside? What if they are so perfectly effective because they are actively mimicking a secret hormone our own bodies have been making all along?
It definitely changes your perspective.
The line between deadly poison, life-saving medicine, and human biology is a lot blurrier than it looks from the outside of that pill bottle. Thank you for joining us on this deep dive.